About every 2 weeks to once a month, we run a free masterclass on osteoporosis. This is where I will go through how we look at osteoporosis through the lens of HealthSpan. We talk about our approach to managing osteoporosis and then give a lot of tips and tricks about how you can potentially work on bone health on your own and give you a lot of information about things that you can do at home. Now, in preparation for this, we ask people to send in questions or be prepared to ask questions during the masterclass. And because the response has been so great to the masterclass, literally getting thousands of people registering for these classes, our ability to answer questions is obviously not big enough to be able to get all these questions in. So what I wanted to start doing is to start answering our top 5 questions from the previous masterclass in a video the following month. So now we're going to do probably every other week or once a month, we'll do one of these kind of Q&A style questions, and we'll answer sort of the top 5 most commonly asked questions that we didn't get to in the masterclass. So stick around. We're going to go through the top 5 questions. We've got some great ones to do today. So top 5 questions from this last month's masterclass. I'll see you at the end for, I think, kind of an exciting announcement. All right, so here's the first question, and this is from a gentleman named Rick. So Rick asks, I would like to know your thoughts on a person who has fractured. Is this when medication becomes necessary, especially if it were multiple fractures? With this said, I'm that person. I was on Forteo 2 years ago and now on Boniva. How do you determine how long to take the follow-up medication? So thanks, Rick, for asking that question. So when to take drugs is definitely one of the biggest challenges I see in the bone health space. And I'm going to talk about certain situations, but let me just say this right out of the gate, which is I can't tell anybody what to do through this type of platform, but I can speak to my experience in recommending people to either consider or not consider drugs. Remember, though, that our framework, when we use both the 4R framework and optimization pyramid to create a program, our framework starts from the foundation and works its way up with drugs at the very, very top. There's a good chance, because most of our patients do, by the time we get to the top of that pyramid and potentially consider pharmaceuticals, we don't need them. Or we understand that potentially we have enough time to see if all the other stuff is going to work instead. And so Rick's question is very specific about someone who has had a fracture. Now, he doesn't say what kind of fracture. I'm going to assume hopefully not a hip fracture, but we're talking probably vertebral fractures, and has already been on Forteo, which is an anabolic drug, and is now on the follow-up drug, which in this case is Boniva, which is a bisphosphonate. So the principle here that his doctor is using is let's build up your bone with an anabolic drug, and then let's put you on a drug like a bisphosphonate, or Prolia could also be used for this to help slow down bone loss. And that's a very rational approach. Now, Rick, I don't think he mentions how old he is. This is a rational approach, but it has a very short window, meaning that Boniva, the different recommendations for different drugs, but probably around 3 years, maybe up to 5 years before you have to come off of that drug. So he was on Forteo for 2, now the bisphosphonate for 3. Now, if Rick is maybe in his 80s or 90s, this is a reasonable approach because we don't know what to expect from a lifespan perspective. But if Rick is in his 60s or 50s or even 40s, then we really have a problem here because our window for using drugs is very short compared to what would be hopefully his health span and lifespan. So his question is, how long do you take the follow-up medication? And unfortunately, the traditional medical model would say you take it until you don't need it, which is either you find another solution or you no longer have osteoporosis, which isn't going to happen, right? And so this is the myopic view, the short view of using osteoporosis drugs without creating an additional comprehensive plan. And this is what I always say about drugs, which is I'm not anti-drug. I just don't think that we need them as often as they're prescribed. And even if you're going to go on a drug, you really need to go on the drug with the idea that I'm going to create a comprehensive plan so that maybe I can come off this drug. Maybe I don't need this drug once I get everything in place. And then only go on the drugs when you have no other choice. And so I think in this case, I would say, well, you're now on this bisphosphonate, so let's ride this wave. Hopefully you got some good response to the Forteo, but let's create a plan that's going to address the underlying cause and root of the bone loss. Let's see where your bone is now, what's your bone quality like, what are you able to do physically, what's your gut working like, what's your nutrition look like. Let's fix all of these things in that optimization pyramid and work our way to the top, and then decide if we need to continue on that drug. If somebody comes off of a drug like, in this case, Boniva or Prolia, there is always that risk of losing bone. So if anybody's working with a doctor to do this, make sure that you're testing, make sure that you're checking your bone biomarkers, your turnover markers, to make sure that you're not going into this phase of rapid bone loss, and then repeating your imaging as often as is reasonable, so that you can really catch bone loss before it starts to get severe if your plan isn't working. So that's the third R of the 4R framework, which is to retest and make sure that whatever you're doing is working, because you never want to stick your head in the sand and just assume that it is, because for most people, osteoporosis is asymptomatic, right? You don't feel bone loss. And so it's really important that you do that. So I hope that answers that question. All right, the next question is from Sophie. So Sophie writes in and says that she was recently diagnosed with osteoporosis, and she was shocked about this, which is not uncommon. She has what she was told is a moderate fracture risk category. She's 51 years old. She's postmenopausal, having been exercised for many years. Now very confused with what she should do or not be doing, and feels limited and because the limitations that have been put on her. She finds that many of the recommendations are geared toward an older demographic, and her doctor said that she's, quote, not fragile, end quote, and to do weight-bearing exercise with no more than 10 pounds. And she reports not having had any previous fractures. So yeah, this is a really common scenario. So we see most of the people that are coming into our program are in their 40s and 50s and 60s to some extent, but mostly we're getting people that are diagnosed early. And I think the reason for that is because they generally will feel very helpless when they start looking at the information out there, because it seems like it is for an older population. And that's because for the most part it is. So there are a lot of things at play here. So one thing to consider is that doctors are always going to lean to be very conservative from a recommendation of lifestyle or treatment modality. Anything that is going to limit the potential risk for you is what they're generally going to recommend. Because risk from a medical legal perspective is not something that they're interested in putting their neck on the line for, especially when they have a solution that doesn't require putting you at any risk from a lifestyle perspective, which is drugs. So now you have this kind of imbalance of risk benefit in the equation when a doctor leans on drugs to treat osteoporosis, because when a doctor says, yes, go lift weights, or yes, go change your diet, they have very little control over what you do. And if you get injured and you say, well, that doctor told me to jump off of a pull-up bar like the Lift More trial, or go do OsteoStrong, or any specific recommendation that they make, they are then liable for. And the lifestyle recommendations are, let's face it, going to put them at much higher risk than, say, recommending a drug for which they kind of already have this built-in coverage for. And so a traditional medical system recommendation for lifestyle is going to be very light. It's always going to be light. So for this doctor to say, do weight-bearing exercise, but don't lift more than 10 pounds, right? Like, that's a very safe statement. That doctor is not going to get you into trouble by telling you to lift more than 10 or less than 10 pounds, right? However, you're also not likely going to reverse your osteoporosis if you're not lifting more than 10 pounds. So then what do we do? And I get this question all the time, because people say, well, they told me to lift weights, but then told me not to lift any weights. Like, I don't know what to do. And so this is why in our program, and whoever you're working with, whether it be a trainer, a physical therapist, an orthopedic surgeon that has a fracture liaison program, whatever it is, make sure that they have a good understanding of what fracture risk really is, and ask them, how aggressive can I be? I want to be aggressive. I want to do this naturally. I want to stress my bones. And if you think about what your bones should be capable of handling with the right form, it should be a lot more than 10 pounds. But I can't safely say that everybody with osteoporosis can do that, because there are some people that are extremely fragile. So it's a very difficult balance. That's why when we bring people in, they meet with our PhD exercise physiology teammate, and he will look at their labs. He'll look at their form and say, okay, I think you should start here. These are some limitations to consider. And then we progressively overload them. And this is a very basic exercise principle, this progressive overload principle. Start low, work your way up. Let's not get injured. Don't just start doing heavy weights. Don't just start doing anything where your body's going to be in an awkward position, because you will definitely get into trouble. So you have to be smart. You have to work with people who understand what they're doing. And there are a lot of people out there, but if you're confused because somebody told you to do weight-bearing exercise and lift heavy weights, but not lift more than 10 pounds, you're absolutely right. Those are contradicting recommendations. Also, anybody who is in this age, the specific age group, I think there's a question in here about hormones coming up. But if this 51-year-old woman who is postmenopausal is early postmenopausal. Definitely having a conversation about the risks and benefits of hormone replacement would be something we would certainly have a conversation about, but always in light of the entire health optimization pyramid, understanding why she's losing bone mass, and then reversing the causes of bone loss, and then creating a comprehensive program to fix it. So I hope that answers that question. If you're finding this valuable, please do me a favor and leave a comment below. And if you haven't already, please click that subscribe button. If you click the subscribe button, it helps YouTube to know that you like this information, that YouTube should put it in front of more people that are doing searches for bone health and osteoporosis. So help me help them by clicking that subscribe button. Thanks so much. Okay, so this third question is from somebody whose name I can't pronounce, so I'm not going to try. But basically, the question goes like this. If one decides to stop Prolia and not take any other bone strengthening drugs, will the bones eventually revert back to building bone the natural way? If so, how long after you cease taking Prolia? She goes on to say, I'm aware that if you have osteoporosis, it's slower, yet does the natural bone building pathway eventually resume? So interesting question. There's a lot of controversy around what happens if you stop Prolia. Does it actually increase your risk of fracture? Can people come off of Prolia? Is this a reasonable thing to do? And certainly this is the fear that I have of patients that get started on Prolia without knowing this potential issue, which is they'll go on it, they don't want to take it forever, but nobody actually mentions to them this potential increased risk of fracture if you come off of it. Particularly for younger patients, like the last patient we talked about in her 50s, if somebody recommended that she go on Prolia and we have safety data out to 10 years, okay, well that gets you to 61. Well, now what? And so probably she's going to have to come off of it. Some doctors would say, okay, great, now let's go on a bisphosphonate. So, okay, that buys you another 2 to 5 years. Okay, now what? There is nothing after that. So I think that Prolia is potentially a good drug for some people, but we have to do this through the lens of what is your lifespan, expected lifespan, what is your desired health span, and then what is the overall goal. So for somebody that wants to come off of it, we do help people do that. We have had good success with that. But the point of this is that you have to then take this, as I keep saying over and over again, this comprehensive approach. We have to figure out, okay, Prolia was helping you to slow down bone loss. So now we got to figure out what other potential causes of bone loss are there. And then as we come off of this and your osteoclasts start working again, let's really follow this thing closely and make sure that it's not ramping up. Let's also make sure that we're building bone adequately. Let's fix this metabolic dysfunction. To get back to the question though, how long does it take for that metabolic dysfunction to resolve? Because the half-life is pretty long. That's why the injections are every 6 months. Because the half-life is pretty long, it's going to take months, potentially even years, before all of that drug is out of your system to the point where you have normal bone metabolism. But that doesn't mean we need to wait years to do anything about it. It just means we need to, get on it, develop a program, be as aggressive as we can in a responsible way so that we can prevent that bone loss. So I hope that makes sense. It is a very challenging problem for a lot of women because they realize that they can't be on this drug forever. They don't want to be on this drug forever, or potentially they're having side effects of this drug and they want to come off. And then the question is how. And so that can be really challenging. All right. So the next question is from Carol from South Wales in the United Kingdom. I love our international audience. So she says that I have indicated on one of my YouTube videos that osteoporosis can occur for various reasons, one of them being hormonal. I want to know if there is an easy way to test for that. Also, is there a safe way to take estrogen if there is a history of breast cancer in the family? Her mom, as they would say in England, her mom had it in her 50s. She's 63. She was diagnosed with osteoporosis via DEXA scan earlier in the year. So this is a very controversial topic. So this is the way that the research sort of puts it out there, which is that there is an increased risk of breast cancer with estrogen. Now, I'm going to take a step back from that and say that actually that's not true in all the studies. In fact, most studies on estrogen, specifically estradiol, and even more so estradiol provided topically and not orally, actually potentially can even decrease your risk of breast cancer. So there's a lot of debate here because even the Women's Health Initiative, which everybody remembers as the study which showed that estrogen caused breast cancer, actually in the estrogen-only arm, there was a trend toward protection from invasive breast cancer. In the combined arm that had both an oral estrogen, Premarin, as well as Provera or medroxyprogesterone acetate, the combined trial did show a subtle but legitimate increased risk of invasive breast cancer. But when you look at additional studies on the MPA or the Provera or the progestin part, we know that progestins outside of combined hormone replacement will actually also increase the risk of breast cancer. So I think my takeaway from the Women's Health Initiative is not that estrogen causes breast cancer, it's that progestins potentially can increase your risk of breast cancer. So small aside there. But that said, I don't think it's also safe to say that we can just give estrogen to every woman and not care about the risk of breast cancer, because let's face it, if you have a risk of breast cancer, which every woman with mammary glands does, right? Every woman has a 1 in 7 is the United States numbers, 1 in 7 risk of developing breast cancer in her lifetime. So if we put everybody on estrogen when they're postmenopausal, will some of those women develop breast cancer? Of course they will, right? We still have a 1 in 7 risk, even if there's no increased risk of providing estrogen. So that's a really challenging thing to have a conversation about. Now, let's take this a step further. So for Carol, she says, well, my mom in England had breast cancer in her 50s. Now, we don't know, was this a genetically driven breast cancer? Is the BRCA gene in play? We don't really know anything about this, or whether it was even estrogen dependent. We don't know anything about this breast cancer. It's always helpful if you could learn that, because it can help to make some decisions around this. And then we also have to ask other questions. Okay, well, what about any other female family members? Do you have any sisters? Does your mom have any sisters? What about grandparents? Is there a sign that there is a strong genetic family history of breast cancer? If there's a single family member, we can take that into consideration. There are plenty of doctors that would say, look, if your mom had it, don't do it. I think the challenge with that statement is that you are protecting, as a physician, you want to protect your patients from developing cancer. Of course you do. But we know that this patient has osteoporosis. We don't know that they actually have an increased risk of breast cancer, although statistically it would, because she has a family member, but it's subtle, right? So what I like to point out to patients and then help them make a decision around this, which is, yes, we know that there is a risk of breast cancer in all women. There is a slightly increased risk of breast cancer in women that have a single family member that has had breast cancer, but we know that you have osteoporosis. So let's talk about options that don't include estrogen. But if we were to add estrogen, which would you rather really focus on? The problem that you have, or the problem that we hope that you may not get, but the risk is somewhere around X? And so that's a very one-on-one individual conversation that is challenging to have, but that's the route that we take. And I would say that, probably most women in this situation don't want to start estrogen because of that potential risk. They don't want to go down that pathway. And that's totally understandable. You don't have to use estrogen to treat osteoporosis. It's an option, but the risk benefit you definitely have to have a conversation around. The other thing that's interesting in here is that she says she's 63. So this actually brings up another really important point that she didn't actually ask about, which is that she's probably over 10 years out from menopause. So that same study I mentioned earlier, the Women's Health Initiative, would indicate in a sub-analysis that if you are over 10 years out from menopause, there's an increased risk of having a cardiovascular event or a stroke if you were to restart estrogen after 10 years from going through menopause. So I think those data are real, and the physiology behind it makes sense, which is that when you lose estrogen, and this is true for both men and women, when you lose estrogen, your arteries will start to get a little bit harder. Harder arteries are more likely to develop plaque because they don't have the natural fluidity of the vessel is supposed to have. And so if you develop plaque over the course of those 10 years that you're off of estrogen, and then you give it back and that artery starts to become more compliant again, could you break off a chunk of that plaque, and could it go to your heart or your brain and have a stroke or a heart attack? So that risk is a little bit more difficult to evaluate. So we know that there is an increased risk of events if you're over 10 years out, but again, that's assuming that you have developed plaque. And this is something we can go down this cardiovascular, risk pathway. We can look at family history, personal history. You can do cardiovascular imaging. You can help to determine this. But again, we are then faced with that same decision of, do we treat the devil we know, or do we treat the devil that we don't know? And again, this is another challenging conversation. There are ways around this. There are other opportunities. Again, we don't have to use estrogen. I could never say that it is safe or 100% safe. Nothing is without risk. But I think the risks of estrogen are probably far outweighed by the benefits for most people. But again, that's a challenging conversation. So number 5. So Nancy asks, she says, I'm reading that our bone density is not the biggest risk factor for future fractures, but rather the risk of falls that we face as we age. Shouldn't greater attention be given to reducing the risk of falls rather than the enormous attention given to exercise and nutrition? Nancy, I think the answer to that is, I don't think it's an either or, I think it's an and. So this actually goes back to one of the questions we talked about earlier from a younger woman, which is there's actually considerable effort and time given to the idea of fall prevention. But this is really going to be more directed at the older population of people with osteoporosis. So, if you are in your, 70s, 80s, 90s and beyond, you are much more at risk of falls from various reasons than is a woman in her 40s and 50s. And so our focus is really to help reverse osteoporosis in really a younger population, but that doesn't mean that you can't do it in an older population. We just have less runway to do it. So as we get older, I think it's relevant to start saying, okay, well, we really need to be focusing on activities that will help us to prevent falls. So what are those things? Well, those things are, using the rebounder, the trampoline with the handles on the side. A vibration machine can be really helpful to help prevent falls. Just resistance training in general can be helpful. I also like this idea of tactical training. So I get this from Peter Attia. He talks about his centenarian decathlon. And one of the things he trains for, very specifically in exercising, is getting up off the ground or getting to the ground, right? In a responsible manner. If you do fall, can you get up? So, training these things as we get older is important. And there is a lot of information out there about this. It's not very popular because people don't want to talk about it. People would much rather debate nutrition and tell you why my theory is right and your theory is wrong. So that gets a lot more airplay on social media and YouTube channels and et cetera, because preventing falls is not sexy, but yes, it's needed. So I think your point is valid, Nancy. So it is out there, though, if you take a look at that. It's not necessarily our focus, although maybe we should do more on it. All right, guys, that is all 5 questions from this last masterclass. If you found this helpful, please let me know. You can leave comments rather in the Q&A area below. If you have additional questions, you can drop them in there, and we're happy to get those in queue to answer. We spend a lot of time answering comments through the YouTube platform, so we really appreciate all this interaction. If you find value in this, I would really appreciate you clicking that subscribe button. If you haven't yet, you can download our free ebook by going to the link in the description, and you can download the free ebook, or you can buy it on Amazon. If you want to have an opportunity to ask Q&A questions, and you've already been to the masterclass and you recognize we don't have that much time because we have so much information to present, we do have a new opportunity that I told you I would announce. So we are launching something called our HealthSpan Nation. So the HealthSpan Nation is going to be a combination of our bone health population as well as our health optimization patients. Most of you know that I run 2 parallel companies. One is specific to bone health, but the other is health optimization. And so I have been brainstorming a way to bring together these 2 very motivated patient populations and offer them something that I think a lot of people are going to love. So what the HealthSpan Nation is an opportunity for you to join with and talk to other people that are in a similar situation, that are looking for ways to optimize their health. And we will do weekly Q&As with kind of topic-driven Q&As, myself and my team members. And if you join the HealthSpan Nation, you'll have access to do that. You'll also get access to all of the recommendations, the discount codes from our podcast, our new podcast, which I haven't talked about yet. But the Dr. Doug Show is a health optimization podcast. It's on a different channel on YouTube if you want to check that out. Again, slightly different, but I think a lot of people on this channel will really like that. So if you want to join the HealthSpan Nation, that's going to be in the description of this video as well as a link to the new channel, the Dr. Doug Show. We're not going to stop doing Optimal Bone Health with Dr. Doug. We're just going to run them both parallel. And so I hope that all makes sense. Thank you so much for your time. I'll see you in the next video.